Hello everyone, welcome back. Today I'll be covering regarding a post-total hip replacement prosthetic joint infection PJI. Another one of my final year exam master question. I hope this video will help you too in your exam. Okay, now let's get started. A 65-year-old male with underlying hypertension, diabetes mellitus, with BMI of 32. He slipped and fall, sustained a close displaced intracapsular right femoral neck fracture. He has an active lifestyle without previous history of hip pain. Surgical options for prosthetic replacement are discussed. Question A. Discuss the option of treatment, the advantage and disadvantage of each option. 8 marks. Options are the hemiarthroplasty versus a total hip replacement THR. For hemiarthroplasty, the advantages is it can be used in an elderly patient with multiple comorbid disease and limited mobility. Shorter surgical time with less blood loss. Less complications associated with major surgery. The disadvantages of hemiarthroplasty include it could not be used in patients who has an arthritic changes, especially at the acetabular region, stress at the articular cartilage of the acetabular region leading to progressive pain. For total hip replacement, the advantages include younger patient with active lifestyle. It has a greater range of movement of the hip, less pain compared to hemiarthroplasty. Total hip replacement longevity is longer, sometimes up to 20 years. The disadvantages include longer surgical time with more blood loss, more complications associated with major surgery, more expensive compared to hemiarthroplasty. During follow-up, 3 weeks after total hip replacement, patient complained of pain and discharge from the operation site. Patient has a temperature of 38 degrees Celsius. Clinically, there is redness, swelling of the surgical wound with hemoserous discharge. B. Possible risk factors for infection. 2 marks. Okay, remember sometimes I always add in answer for additional purposes. 1. Diabetes mellitus. 2. BMI of 32 in patient obese. 3. In older patient has high risk of infection. C. List the laboratory studies and its relevance. 3 marks. Remember, I want to discuss this so that you guys can answer it more thoroughly, not only short notes or something else. Number 1, the C-reactive protein CRP more than 10 mg per liter is taken from the blood, has rapid result and cost effective. It may be elevated post-operatively. The threshold value may be different in the early post-operative and late chronic prosthetic joint infection PJI. Number 2, synovial white blood cell count more than 3000 microliter taken from synovial fluid aspiration. The time of collection of the sample and operative site may affect the result. Number 3, leukocyte esterase test. Leukocyte esterase test by synovial aspiration is included as minor criteria for the diagnosis of prosthetic joint infection. It strongly correlates with the polymorphonuclear neutrophils. D. Emergency surgical debridement is done. Describe the technique of debridement. 7 marks. Debridement, antibiotic and irrigation with implant retention (DAIR) is appealing especially for acute prosthetic joint infection. The first step is to reopen the wound and clean any subcutaneous fluids and clots. If the deep fascia is found to be closed, then superficial debridement is performed, collecting separate tissue samples for microbiological study. When this layer is macroscopically clean, synovial fluid is collected with a needle. In order to get a sample of uncontaminated synovial fluid, and then deep fascia is opened with a new set of instruments. After arthrotomy, the mobile components are removed in order to increase access and allow better cleansing of all prosthetic interface. A thorough and meticulous debridement of all devitalized tissue and extensive synovectomy are performed. 5 tissue samples are systematically obtained. After a thorough excision of suspicious tissue and removal of all the suture material, copious irrigation is performed. 3 liters of chlorhexidine gluconate scrub are used initially, followed by another 3 liters of saline solution. After this step, the wound is temporarily packed in sterile compressed dressing and the surgical team change the glove and protective clothing, and a new set of sterile surgical tools are used. An additional 1 liter of saline irrigation is performed prior to the replacement of a new mobile components to replace those that has been removed. The drain is used. The wound is closed in layers as tightly as possible using techniques similar to the primary surgery. Culture taken suggests deep periprosthetic infection, coagulase negative step aureus. Cons. What is the management? 2 marks. After proper debridement, long-term antibiotic is used. The ideal antibiotic should be active against a slow-growing and biofilm-producing bacteria and possess a good bone-penetrating ability and oral bioavailability. Rifampicin fulfills these requirements in addition with another antibiotics, example, cotrimazole, fusidic acid, linezolid, ciprofloxacin, and levofloxacin. Yay! We have reached to the end of this video. I hope this helped you in your exam. See you in the next video. Take care and bye.